Good morning, everyone. I now welcome Dr. Srinagesh, who is from Srinagesh Diabetes, Thyroid and Endocrine Center, Clinic, Hyderabad. And he's going to talk to us about growth hormone in special situations. I think this is an important topic because of late now parents and families are coming and asking about growth hormone in different clinical situations.
Yes,
and as pediatricians, we would like to know from the expert where we stand today.
Okay.
Thank you very much.
Thanks for the introduction, sir. And before I'd like to begin, as always, I'd like to thank my dear friend Ganesh and the organizing committee of ENDODIABCON for inviting me for yet another year for this conference. So, the next few minutes I'll speak about the use of growth hormone in something other than growth hormone deficiency. This is the disclaimer. Generally, we have two kinds of growth hormone now. One not very expensive, one fairly expensive. We've got the daily growth hormone, somatropin, which is also relatively expensive. And many a time I tell my patients that the single most important deterrent for use of growth hormone is the price. If growth hormone was as cheap as insulin, more people than diabetics would be on growth hormone. Almost everybody would be on growth hormone. We'd have a tirzepatide and semaglutide like situation for growth hormone. Somatrogon, we've got a weekly growth hormone whose only indication is GHD. Growth hormone, recombinant growth hormone has been around for 30 years. Cadaveric growth hormone was around earlier, then you knew the problems with that, Creutzfeldt-Jakob disease. People had issues with use of cadaveric growth hormone, then you actually had recombinant growth hormone and that was approved in 85. That's exactly 30 years down the line. Since then we've had growth hormone, we've got a huge amount of database including the KICS databases. Initially it was approved only for growth hormone deficiency. Then you had an approval for chronic renal insufficiency, which was the first non-GHD approval. Then you had approval for adult growth hormone for Turner syndrome subsequently. Then you had Prader-Willi. Small for gestational age. Idiopathic short stature was one of the more newer ones. And later on you had indications approval for Noonan syndrome. A lot of other syndromes like Silver-Russell syndrome, which are not a common part of our routine day-to-day clinical practice. But if you don't have a contraindication, you can still give it. And now recently 22, you had a long-acting growth hormone which was approved. This is, I think only one company has a long-acting growth hormone which is approved as of now. So I'll deal with a few conditions, the common ones of among which where we use are, the commonest condition beyond GHD is actually idiopathic short stature. The second commonest would be Turner syndrome. Then you have small for gestational age, you have rare conditions like Prader-Willi, renal insufficiency and Noonan. And nowadays it's also being used in conditions like HIV, endocrinopathy, acquired adult growth hormone deficiency due to any cause or a spillover from a pediatric growth hormone deficiency. Prader-Willi, I'll be dealing in more detail with Prader-Willi because this is not often dealt with in a lot of pediatric or adult meetings. People have this question, the child with Prader-Willi is not short, should I be putting him on growth hormone? The answer, brief answer to that is yes. It's a rare disorder. It is caused by something known as a uniparental disomy, where a set of genes only from one parent are replicated twice on the chromosome, or you miss those genes. It affects approximately 1 in 15,000 to 1 in 30,000 live births. The prevalence is probably higher, but we again do have a bias as far as endocrinology is concerned. We got a randomization bias. Classically seen by neonatal hypotonia, in fact even the antenatal kick score, the fetal movements will be lesser in the baby, the mother will report it if you take a proper history. Feeding difficulties in infancy again because of bulbar hypotonia, hyperphagia and obesity in childhood, they'll have short stature, hypogonadism, fairly well made out in a male, difficult in a female, they'll have cognitive and behavioral challenges and some amount of growth hormone deficiency. Many a times, the single most important problem we have is obstructive sleep apnea. Obesity and metabolic syndrome will be there. Some of them will have delayed motor development. Again, this is partly because of growth hormone deficiency. There is poor muscle development. There is cognitive impairment. Multiple behavioral issues will be there in this condition. Classically, you will have growth hormone deficiency and hypogonadism. Sometimes you will have hypothyroidism. A lot of times it will be factitious hypothyroidism because of the obesity. You will have a rise in the leptin, which will cause a rise in TRH and TSH. And high morbidity and mortality even right from childhood till adulthood. Basically, irrespective of the height or the stature in a case of Prader-Willi, you are supposed to start these children on growth hormone. Because growth hormone deficiency is because of a hypothalamic dysfunction, increased secretion of somatostatin as well as reduced growth hormone secretion. Growth hormone therapy will improve the body composition. Most importantly, it will improve your gross motor milestones. Because motor development delay is very common in Prader-Willi. You will have an improvement in cognitive function, increased energy expenditure, increased muscle mass will be there. It also improves your quality of life, and irrespective of your stature, it's now considered standard of care. And many times the most important problem we have with the use of growth hormone is that there is some amount of hypertrophy initially of the bulbar area, and these patients can present with obstructive sleep apnea or even a SITS. So prior to that, it's always better to do a sleep study. If you can do it, if you can't, this should not delay the initiation of growth hormone, but you have to start with very low doses. Basically start with a low dose and then gradually up titrate over a period of a few months. All patients with Prader-Willi should at least be evaluated annually for sleep disorders, including sleep disordered breathing, daytime sleepiness, narcolepsy, cataplexy and insomnia. And this requires a multidisciplinary approach. You will need an endocrinologist, you will need a pediatrician. You are actually going to need a sleep study specialist, a neurophysician, a physiotherapist and also a speech therapist or a child psychiatrist or a child psychologist, because all this multidisciplinary approach is always needed in Prader-Willi. And food seeking behavior at night can also be because of sleep disorders in Prader-Willi. If you have actually looked at the KICS database, which was established in 86 to prove the safety of recombinant growth hormone, which was introduced at the time, we've had large scale data. This data was there for almost 20 to 25 years. Recently the KICS database was disbanded, but a lot of the research is still available in public domain. It completely normalizes adult height and improves body composition in Prader-Willi. We got multiple papers on this. This is one of those few representative papers. If you look at systematic review and meta-analysis, it will cause an increase of the height standard deviation by 1.67. The body mass index Z scores decrease by almost 50 to 60%, and the fat proportion also decreases in people with Prader-Willi. Your muscle mass improves, your fat decreases. This is how it looks. The earlier you start, the better is your response in Prader-Willi. You got, sometimes in some cases, Prader-Willi might be diagnosed as early as 9 months to 10 months. Even in people who are less than 1 year of age, there are some studies which have actually told you, similar to the Turner infant study, that starting early therapy with growth hormone will improve outcomes in Prader-Willi. Because many of them have delayed walking and delayed milestones, so all of these can be ameliorated by Prader-Willi. And this also has an impact on the cognitive function. Administered properly, adverse events are very few. The second, something which is well known, is Turner syndrome. This is typically how a child would present with Turner syndrome. You got short stature, you got a shield chest, you got clinodactyly, wide space nipples, you will have a webbed neck. These are the classic features by which wide carrying angle, by which you would identify children with Turner syndrome, but there are also a lot of internal problems. Many of them will actually present with a bicuspid aortic valve. The commonest cardiac anomaly you will see is a bicuspid aortic valve. You will also have coarctation, ovarian failure, usually streak ovaries. This can be protean actually. You can even have some women who present with recurrent abortions. When they actually have a karyotype, then they are found out to have a mosaic. But it's not always mandatory that there should be a genotype phenotype correlation in Turner syndrome. You can have somebody with a complete exokaryotype who will still present with normal ovaries. You can have somebody with very simple mosaicisms like an isochromosome or a ring chromosome who can present with the classical features of Turner. But when you see these kind of features, they are classical. It's not always essential that you will get somebody with classic Turner features. Any girl with unexplained short stature, it is worthwhile doing a karyotype. For all practical purposes, the use of growth hormone in Turner syndrome is essentially like a blunt instrument. The higher the amount of growth hormone you give, the greater is going to be the growth. And in all studies, wherever growth hormone has been used in Turner, there is an improvement in height. If you have a taller mean parental height, taller height at initiation of therapy, if you check the response to growth hormone during the first year of therapy, the mean dose of growth hormone, it is slightly higher than what you would see with GHD, but at the same time there has to be a limit as to how much growth hormone you will give. Height at the start of puberty, and most important, age at the start of puberty. The earlier you start, the better is your height in Turner syndrome. And that is the reason why even infants, if they are detected, can give you very good response with growth hormone in Turner. This has actually now become the standard of care. Final adult height is maximized. The gain can be as much as 15 to 20 meters if you start early on, because most of the European databases, the average European to Indian databases, the average height you get with Turner is, without growth hormone, is 137 to 145 depending on the parental height. Dosing again should be individualized according to the parental growth velocity. IGF-1 monitoring can be used to adjust therapy, usually not required. You will get the response right from the height gain. And one important finding which you would actually miss out is, many people don't focus on one aspect. Use of growth hormone increases your uterine size and your endometrial thickness. This was not of very much relevance earlier. But now that we got mechanisms like an ovum transplant, ovum donation, women are going ahead with ovum donation in Turner syndrome. This can assume importance later on. Many women with Turner syndrome actually have a very small uterus. Even with proper use of estrogen, the uterus does not increase. One of the reasons is growth hormone deficiency. Use of growth hormone will increase your uterine size and improve the chances of the woman going ahead with a pregnancy later on in life. The therapy is generally continued until the parents tell you that it's enough, more often than not for reasons of cost, or the growth velocity has decreased to less than 2 centimeters per year, which is true for any therapy with growth hormone. Some increased risks. I've used growth hormone in many women, many children with Turner syndrome. I generally don't see any of these problems. Slipped capital femoral epiphysis, if properly used, is very rare. Intracranial hypertension, scoliosis, pancreatitis. The only problem I've usually seen in these children is that there will be a slight rise in insulin, fall in insulin sensitivity. They might have a slight rise in the blood glucose levels, but I've never had any child who's presented with a frank diabetes. That again depends on your dose. Again, you got to look for other risks with Turner syndrome. Autoimmune disorders are very common because of the involvement of the X chromosome. They can actually present with hypothyroidism, is very, very common, much more common in these children. Type 1 diabetes is somewhat prevalent, as well as hearing loss is common, which is again part of the disorder. Hypertension should always prompt evaluation for coarctation. Always send a child with Turner syndrome for cardiac evaluation. And aortic dissection and rupture, you should ideally not be reaching that stage in a child with Turner. If you actually look at the Dutch Turner dose escalation study, which was one of the earlier studies which was done regarding growth hormone therapy in Turner, included a cohort with some children with the Turner infant study. They looked at growth hormone as per body surface area, which was something which is not generally done. We look at per kg body weight. The doses were much higher than what was seen in GHD. This was how it was used: 0.045 one cohort, 0.67 mg per kg per day, and 0.09 mg per kg per day. The best results were in the group where you use the higher dose of growth hormone, but for reasons of practicality, we have taken a middle path, and a majority of children with growth hormone are recommended a dose of somewhere around 0.67 mg per kg per day. And this was the final height you gained: 158 to 163. Without that, the height was 145. You got an 18 centimeter height gain with a 0.067 mg per kg per day. With 0.09, it was not much. So basically, for statistically significant growth, was best achieved with 0.067 mg per kg per day. And that is generally what we try to give children with Turner. Start with a lower dose, gradually escalate over a period of a few months. The earlier you start, the better is your response, which is always true for Turner. Chronic renal insufficiency. Many children actually present with this condition. This is basically because the increased creatinine and the myelo which is created by the CRI interferes with your action of growth hormone. A lot of time the growth hormone levels might be normal, but they have a relative growth hormone deficiency because enough IGF-1 is not produced. They'll have nutritional deficiencies, metabolic acidosis, which actually affects the alkaline phosphatase and its functions at the level of the growth plate, the anemia, which is almost universal in CKD, and the bone mineral disorders, especially vitamin D and absence of activated vitamin D. This leads to growth hormone resistance, especially rise in urea and uric acid lead to growth hormone resistance at the growth plate. You measure IGF-1, you'll actually see that IGF-1 is very low in these children, even with classically what is seen as a normal growth hormone response. We don't routinely measure growth hormone in these children, but you'll see that the IGF-1 is low. And they also have some psychosocial impact of short stature. Inflammation, like I said, inflammation, IGF-1 bioavailability issues, and reduced GH receptor expression. Basically, when we give, again, the use of growth hormone is similar to what is seen in Turner. You are giving it as a blunt instrument. You can't directly give IGF-1, so you give them growth hormone. It increases your IGF-1 levels, increases your linear growth. Essentially, this is used in these people until they can get a definitive treatment for their CKD. Once they get a renal transplant or renal replacement, or there is a remission in their CKD, the height velocity proceeds normally. Till that point of time, you can actually give it as a rescue medication, because you are going to lose time and lose years. And if there is epiphyseal fusion, there will be no further growth in these children. This can always be considered in children height less than 3rd centile for age and sex. Poor growth velocity despite optimal nutritional and metabolic control, and or pre or post transplant with persistent growth failure. Usually post transplant you will not have persistent growth failure. But that can happen especially in people who receive a significant amount of steroid therapy or other molecules, immunomodulators, for preventing the transplant rejection. And in all these children, thyroid hormone levels including TSH, free T3, free T4 and IGF-1 are measured. These children have a loss of thyroxine in urine, and this can cause, because with the protein albumin there is also a significant amount of loss of thyroxine, and the thyroid gland might not be able to keep up with the thyroxine production demand. You might have to replace thyroxine temporarily. IGF binding protein 3 assessment is generally not done in India. One, because we do not have very large scale normative data studies, and IGF-B protein 3 fragments accumulate in CKD. They can give a false normal values even when there is a deficiency in the IGF-1. Left wrist radiograph, like everything else, is recommended as told by the previous speaker, and children with CKD resulting in hyponatremia and polyuria should receive sodium and water supplementation. Otherwise, they will have intravascular volume depletion, which will again cause a myelo where there is poor growth. And PTH level should be kept within the recommended range. You should have a close contact and close coordination with the nephrologist. 25 hydroxy vitamin D should be kept about 30 nanograms per ml. If required, you should also give them 125 OHD3 depending on the situation. And these are the routine things: urea, calcium, phosphorus, alphos, bicarbonate is something which is out of the ordinary, PTH. Vitamin D, if when in doubt, do a 125 OHD3 also, it will usually be deficient. Thyroid should be done. You should do a fundus examination because they can have some amount of retinopathy. Radiography of the left wrist and do a pubertal staging. Most of the time they will have a delayed puberty. So this is where the role of growth hormone comes in. Till they get a final definitive therapy, you are giving them a rescue medication which improves growth velocity, body composition, because most of these children will be cachexic, and long-term height outcomes before they get definitive therapy. And that is the reason why nephrologists should be aware of the fact that any child with CKD who is growing poorly should also be referred to the endocrinologist. This does not usually happen in routine day-to-day clinical practice. We can count on our fingers the number of children who present to us with CKD and growth failure. More often than not, thalassemia patients actually come to us. I tell them only one thing: don't waste your money on growth hormone, go for a bone marrow transplant. Small for gestational age has been used to describe a neonate whose height or weight is below 3rd centile for age. There are multiple definitions. A simple and easy definition is look at the growth charts. If your height or weight is below the 10th centile for age, small for gestational age. Most of the time, nowadays, as our understanding of genetics and agrican and PTPN1 gene and this kind of understanding is increasing, we are realizing that a lot of small for gestational age and IUGR children have some inborn genetic defects, which is actually causing decreased intrauterine growth and is also causing decreased extrauterine growth. Generally, these children catch up by the age of 2 years. Traditional teaching is 5, but 85 to 88% of them will catch up by the age of 2 years. If they have not caught up by 2 years, it's unlikely that they are going to catch up, and you will have to give them some push or some help to ensure that they grow. Most of the time, defects are IGF-1 and IGF-1 binding protein 3 levels are reduced. There is no lasting effect of prenatal glucocorticoids. This does not usually, we have seen even in children with nephrotic syndrome, there is no long-term effects of glucocorticoid. Pubertal growth can be modestly decreased because they also have a reduced fat mass. They will have reduced ovulation rate, increased secretion of adrenal and ovarian androgens, excess abdominal fat. Again, the Barker and the Pedersen's hypothesis, and hyperinsulinemia, they are all a part of this picture. Reduced bone mineral content, sometimes partially because of reduced clearance of calcium and vitamin D from the mother to the child. Once adjusted for adult height, this is actually not much of a major concern. So beyond the age of 2 years, again there is a dichotomy. In US they are quite aggressive, they start growth hormone after the age of 2 years. In Europe they generally give it around the age of 4 years. But whatever the age might be, once you have identified that the child is SGA, it makes sense to start them on growth hormone therapy because they are unlikely to catch up. There are benefits in increase of fine adult height, bone mineral density, the fat composition, as well as the muscle mass and the motor milestones. If you delay, you might have to use larger doses in these children. Traditionally, shall I go on for 2 minutes? Traditionally, these children will not grow if you give them growth, if you do not give them growth hormone. And you don't need to do majority of this test. We don't do IGF-1, we don't do growth hormone dynamic studies. We just do the routine test for short stature and poor growth. And if they are not usually done, if they are normal, we directly go ahead without assessment or even doing an MRI in these children. And these are the approved indications. Usual recommended dose is 0.035 and then you gradually increase the dose. Most of the studies actually show that there is very good response with growth hormone therapy in these children. Until and unless you give that, they are not going to catch up. Noonan syndrome, often not seen in routine day-to-day clinical practice, very similar to Turner. We call it a male Turner, but essentially Noonan's is present both in males and females. You have to look at the mutation. Nowadays we are doing genetic evaluation now that it's cheaper. Children with PTPN11 mutations respond slightly less. We have to tell them that there is poor response. They have a small or documented risk for juvenile myelomonocytic leukemia. So if they have a normal height, it makes more sense not to give them growth hormone. Growth hormone is not directly linked to leukemias, but still you should be circumspect, and if at all they are very short, start them on this, but keep monitoring their blood pictures. And do a baseline genetic testing. A lot of genetic tests will actually tell you whether the risk of developing a leukemia will be there or not. There are multiple panels which will even predict risk of leukemias. And always do an MRI in children with Noonan syndrome. Idiopathic short stature, again this is a huge topic, I am only going to touch the basics of this. When nothing else works, classically put, when nothing else works, child is short, you don't know what the reason is, they're dumped into ISS. But now we are realizing that ISS has a huge genetic basis, especially in the Asian population. Height standard deviation score less than minus 2.25, unlikely to reach the adult height. IGF-1 levels might be low, they might be normal in this child, but when you don't have any indication, you start putting them on growth hormone therapy. This is USA FDA approved in 2002. This was one of the last indications for growth hormone therapy. Should not be considered before 5 years of age and should be stopped when the height is completed or you are getting very little gain. This is one disorder where you spend the maximum amount of money for the minimum amount of gain. Better response, you get a lower IGF-1, you get a better response. If the parents are taller, you are better off. If you got a low baseline height velocity, chances are that velocity will improve with growth hormone therapy. Lower bone age and of course greater dose of growth hormone, but within bounds of reason. There are multiple RCTs, all of them will give you varying pictures, but wherever there is a genetic underpinning, your chance of getting growth is more. Where there is less genetic underpinning or there is familial short stature with normal growth velocity, your chance of getting a response is much lesser. The last part, this is a common problem we face with the parents. They come to us and tell us that the child is not taking growth hormone. Proper growth hormone is, they are very truant as far as administration of growth hormone is concerned. Do we have an option? All these days we didn't have an option. Now we've got an option which is known as weekly growth hormone. There are only 3 questions whenever we start anybody on weekly growth hormone. 1, does it work? 2, the usual question of any parents, even if you put the child on distilled water, is it safe? 3, is it more expensive? The answer is yes, it is frightfully expensive. But in truant children, it works, and the response with my personal observation is much better with weekly growth hormone, because if you give daily growth hormone, there is some amount of non-compliance in children. Weekly one takes care of it. Adherence is always better with weekly growth hormone as long as cost does not become a factor. Many a times parents stop growth hormone therapy because of poor response or because of the child praying truant. Long-acting growth hormone regimens actually ameliorate this problem. You have less injection frequency, you have better compliance, and even if you skip an injection or 2, the effect on growth therapy will not be so bad. Basically this works because you got 3 CTP sequences from the beta chain of HCG fused to human growth hormone. It improves the half-life, extends the clearance of growth hormone from the circulation. Mechanism of action is similar to human growth hormone. Short term it is safe. Long term we are still waiting for data. We got 5 years of efficacy data. To actually look at full long term data, we will have to wait for 30 to 35 years to see whether these children actually had a higher incidence of cancers later on in life. At this point of time, there doesn't seem to be any mechanistic or in silico signal or in vitro signal for that. Studies have been done in multiple sites. You got representative data. All these criteria actually told you that plasma growth hormone levels, plasma IGF-1 levels increased. You had a data which was similar or non-inferior to normal daily growth hormone therapy. Most of the patients achieved similar height outcomes as opposed to people who were on daily growth hormone. In fact, clinically, the height velocity and the outcomes are better with weekly growth hormone as opposed to daily growth hormone. But it is indicated only in GHD. All the other conditions, what I have told you about, it is not indicated at this point of time. And of course, patients and caregivers, especially in the West where it's supplied free of cost, will definitely like it. Indians don't like it so much because it is more expensive, and we had a short period of time when growth hormone was not widely available and we got only weekly growth hormone. Whether that was intentional or accidental, I can't say. Company says it's accidental. That can be the case because worldwide we had a global shortage of growth hormone. So to conclude, this is what I'd like to say. One last one is growth hormone in adult onset GHD and HIV. Adult onset growth hormone disease, even though you have a pediatric growth hormone disease, by the time you become an adult, the little amount of growth hormone which is produced is usually enough for an adult, but in very severe cases, or where you had a pituitary tumor, craniopharyngioma, where the surgeon has dug in completely, you will not have growth hormone. To improve body composition, to improve the bone density, you will have to use growth hormone. You will have to stop growth hormone therapy for 6 months as a child and retest them again. Later on, even in trauma or tumor associated adults with pituitary macroadenomas and those kind of tumors, you will have to test for adult GHD. HIV associated endocrinopathy, especially people with severe cachexia, it works, and in wasting syndromes. Hypothalamic injury and radiotherapy, post-craniopharyngioma surgery, long-term survivors of hypothalamic tumors, especially people with so-called hypothalamic obesity, this again works very well. To conclude, generally whenever we look at anybody with a pituitary problem, the one thing we always ignore is IGF-1 and growth hormone, in children as well as in adults. Many times pediatricians should please take note, sir. You keep telling children that they will grow and you will send them to us after 13 years of age. When we can only give them reassurance, please send them at 3 years of age. I am not telling about anybody in particular. Even I was a pediatrician at one point of time. Probably I also told them that this fellow will grow, they will not grow. You will have to send them. Growth hormone is very essential, but parents are usually picked up late. Early initiation, this is the most important thing, and individualized dosing maximizes height outcomes and metabolic benefits. It improves body composition, it improves muscle mass, physical functioning. Gross motor delay is usually ameliorated by growth hormone, and quality of life across multiple conditions. And wherever the parents are unwilling for daily growth hormone, they can afford it, and the indication is a proven growth hormone deficiency. Long-acting growth hormone formulations may enhance adherence, and in a lot of these conditions, especially special situations, we will need a multidisciplinary approach. In fact, there is another aspect to this, the last point. There is a huge amount of controversy whether you should actually be doing a growth hormone stimulation test. I have developed very diverse views about it. In a majority of situations, I generally think that GH dynamic testing is basically useless, especially if the child is very short. Because what are we going to do? We do a GH dynamic testing, which is not very well validated. If you actually go back and look at the data, you'll find out that that is the one thing in endocrinology which has the least amount of data. You do a GH stimulation test, that will be normal. You give him reassurance, he doesn't grow at 6 months, anyway you are going to club him as ISS and start him on growth hormone. I think as a community we need to have a rethink about growth hormone dynamic testing. That's it. Thank you, sir. Extremely sorry for overshooting my time massively.
Thank you for a very practical lecture on growth hormone, especially highlighting Prader-Willi and Turner syndrome as indications for children, and especially more so with Prader-Willi, identifying obstructive sleep apnea, starting them on treatment for obstructive sleep apnea before growth hormone. Thank you, sir.
Thank you.
Any question and answers?